I think without too much further ado, I'll introduce Jack Natalotto. So Jack, if you want to come up to the podium. Jack's studying a Bachelor of Science in Medical Radiation Science, and Jack received his internship scholarship for the project Interactive 3D Virtual Reality Imaging of Abdominopelvic, I knew I was going to muck that up, sarcoma, which is a type of cancer, to improve surgical planning. This project has been supervised by Professor Zhonghua Sun, who's in the back, the project's receiving funding from the Harry Perkins Institute of Medical Research, Heart and Vascular Research Institute, so we very much appreciate our external support for that particular project, both for the scholarship and also supervisory as well. And I will now hand over to Jack. Welcome, Jack.
G'day, I'm Jack. I'm a radiography student in my final year. My penultimate placement starts on Tuesday, so that's pretty cool. As introduced by Ando, I am doing virtual reality imaging of abdominopelvic sarcomas to improve the surgical planning. So we set out this with the objectives of segmenting multiple cases of abdominopelvic sarcoma in various colours to be easily identified in virtual reality, meaning you can see what structures are and where their borders are. Within the virtual reality experience, we wanted these structures to be able to be manipulated or the entire structure, so you can rotate the entire structure. So let's meet our patients. First off, we have OP. They present to us today with weight loss, fatigue, and central abdominal pain. On a CT scan in the portal venous phase of enhancement, we can see a central pathology with heterogeneous density, meaning it's a bunch of different grey colour planes here. Now we have another patient, AS. They present to us today with jaundice and right-sided abdominal pain. Again, their CT scan in the portal venous phase of enhancement shows a heterogeneous lesion with areas of central low density. This is right-sided and it's in the liver, and you've got the kidneys there. So what is this? This is called a leiomyosarcoma, meaning, and it originates from smooth muscle. It's a very silent cancer. You only really see it, or it only causes symptoms when it impinges the function of vasculature or an organ. So in the case of AS, they're jaundiced because it's impinging the function of the liver. So are there any other types of sarcomas in the abdominal region? There are two other types. You have a liposarcoma, which lipo meaning fat, and you have a gastrointestinal stromal tumour. However, these aren't in our cases. So how are sarcomas treated? Neoadjuvant radiation therapy, meaning that's the first thing they do is radiation therapy, just to try to shrink the tumour. That's the first thing we do. But the only known curative is surgery. Now, why may surgery be difficult? Let's have a look at this. We've got the cancer around here, and we've got the vena cava here. How difficult do you think that would be to operate on? And now let's look at this. We've got the cancer around here, and the aorta here. That is extremely difficult to operate on, especially with the limitations of 2D planar imaging. So let's try give the surgeons an edge. Let's create 3D models to be used in virtual reality. So because this is new and it is research, we import anonymized data into a free software called 3D Slicer. Now we're going to do this manually for OP. The first thing we do is we select a threshold for a desirable range of Hounsfield units in the voxels. Now Hounsfield unit is just how grey something is in a voxel. I'm not the guy to be talking about the CT physics, so I won't go into that. So using the paint function with our selected threshold, we then colour in the scan. Now that's a bit of an oversimplification. Colouring in is the segmentation. We're selecting a desirable voxel to then be used in 3D. And here we have our 3D. It's not very good. You know those Dippin' Dots, those little ice cream pellets you used to get outside Wildcats games? It kind of looks like that. So with a little bit of magic and a lot of smoothing, we get something that looks remotely organ-like. Now, there are 9 structures, 9 colours on here. To be more accessible in healthcare, colourblind people can see 9 different colours. Whether they look good or not, that's up to you. I can imagine clinically we will be changing them up to a preference. This took 30.32 hours to do all by hand, by the way, with the intestines most notably taking 16 hours. So with 3D Slicer, we can create clinical scenarios. We can toggle on and off organs, and we can change the opacity. So one thing I wanted to show was the sarcoma in purple. I chose purple because it's symbolic of hematoxylin and eosin stains. The pancreas in yellow, arterial supply in red, which also contains the renal arteries, superior mesenteric artery, celiac trunk with the left gastric artery, splenic artery, and hepatic artery, and the vena cava in blue with the renal veins. Now, this shows a really good spatial relationship compared to the 2D axial slice, where the borders are pretty difficult to visualize. So would this be helpful in preoperative planning, knowing you can see how it looks in 3D, because people are 3D and not 2D? Crazy. But 30 hours, that is way too much time. Management will have a sook when I put that on my timesheet for 30 hours of overtime. We have to find a different way. So for OP, we try to do it automatically. We imported OP's anonymized data, AS's anonymized data into 3D Slicer. We use the total segmentator extension, which utilizes an AI that knows over 100 pieces of anatomy. And then we analyze the final products for discrepancies. So it knows over 100 pieces of anatomy. Considering there's 206 bones in the body, that's not really a lot. But it did a pretty good job. You got the portal veins there. It recognized that that's not liver. However, in maroon, we have the liver, and that's our cancer there. We've got our cancer over here. It thought the cancer was part of liver. So I go, okay, automatic is not going to work. We need to do this semi-automatically. It's kind of scary being outsourced to a computer, you know, watch out radiologists, you're next. This in total depends on your kind of computer specifications, kind of up to 5 minutes. This one was 5 minutes by hand, which I had to also do the renal arteries because that wasn't done automatically. And the branch vessels, like the superior mesenteric, celiac trunk, hepatic, splenic, left gastric, they also weren't done. So they had to be done by hand as well. I think it's really interesting to note how I got the musculature on really well. The pelvic musculature right over my head in anatomy class. So it's really cool to see it on here, and especially the spinal musculature too. So again, we can then create clinically relevant scenarios. I chose the gastrointestinal system, sarcoma in purple again, the duodenum, which is the first part of the small intestine, in white, and the colon in vomit color. You can see how it may impact those pieces of anatomy in 3D. In virtual reality, it's easier because you can spin it around, and this is just spinning. But you can see how the lesion may be impacting the anatomy compared to how it is on a planar image, a 2D. You've got the duodenum there and a lesion. There's just difficulty in the planning here 3D may be able to help with. So now we have our two cases. We then import them into 3D Slicer. We use the Slicer virtual reality extension. An older version of 3D Slicer, by the way. We then use the Slicer virtual reality extension, and using an Oculus Quest 2 and Steam VR, we can play around with them in virtual reality. So the VR experience is kind of bare bones. The controls are a little bit janky. You can scale in, out. You can rip apart organs, which after showing a few surgeons yesterday, that was what they liked the most. They liked being able to grab an organ, spin it around, have a look at how the cancer impacted that in particular. Essentially, when you move towards it, the segmentation is stationary, and you are a camera and flying towards the segmentation. However, there's not really a lot you can do other than have a look. You can't really place measurements in virtual reality. You can't take screenshots, which I know in theatre, I've seen my x-rays up in theatre, so I'm sure you can take screenshots on here, place it in theatre with labels and measurements. That might be something you can do. A UI would be really interesting to have, where you can turn on and off. Yep, let's turn off the lungs. Let's turn off left rib 4. Let's change the opacity of the sarcoma to 100 and the aorta to 0.4. Something the surgeons did note yesterday, they really liked when you can mess around and go into the vasculature. So maybe trying to fly through experience with virtual reality. When we're in healthcare talking about fly through, that means going through a structure, if that makes sense. So imagine you got your artery, it's hollow, and you fly through it. That's what fly through is. It's done a lot in CT colonography. So future research. Firstly, do the surgeons think it's a good idea? There was a study done in about liver lesions by an author who I cannot pronounce the surname, and they all were really positive about how it could improve surgical planning. However, they did mention that there is unreliability in imaging. Does it even need to be in virtual reality? Could we have the multiplanar imaging and our 3D structures on a screen? And then, you know, the surgeons yesterday were really positive about where this could be improved to. This is a good baseline. They liked the usability of virtual reality. So maybe if we work with them to get something that tailors to their more specific needs, will it actually help improve the resection margins? And if it doesn't, does it help reduce any intraoperative complications? We saw how close these lesions are to vasculature. I can imagine there's a lot of complications. Now, a psychological one that's kind of interesting is, does it affect a surgeon's confidence before the operation? Being able to see something in 3D versus in 2D, again, people are 3D, that might make them feel more confident in their plan, in their process. I don't know. I'm not a psychology guy. I just take the pictures. Now, when talking about education, there is a few studies done in education, lots of them in nursing. Could we then implement this to not replace radiology, we should never replace it, to supplement the learning of medical students in their anatomy and pathology education? And then maybe we could increase this up through the chain, you know, interns for CPD, registrars in teaching, consultants CPD, and fellows for their teaching. I think that would be quite interesting. So to summarize, we made two segmentations, automatic methods and semi-automatic methods. We found semi-automatic methods is probably what clinically should be done at this point in time. We did them in multiple colors so you can visualize different pieces of anatomy and their borders. And then we can utilize this in virtual reality to move an entire object around or an individual structure. You can pull it out, have a look, place it back. Hopefully this can be used by surgeons with a further improvement to plan their operations and improve outcomes of patients. I'd like to thank Zhonghua, Carley and Shirley for their support. I'd also like to thank Joe and Rob for coming out yesterday and having a mess around with the virtual reality and providing feedback. Cheers to the Harry Perkins Institute of Medical Research and the Heart and Vascular Research Institute for funding this project. I'm really excited to see how this technology can evolve and how it can develop into clinical practice. Cheers, thank you. Any questions?